Good morning. In this video, we will talk about a fairly common cause of residual pain after a simple ankle sprain, but the same cause can also be a source of pain and joint stiffness after an ankle fracture that has been operated on or treated without surgery. I am referring in particular to the development of scar tissue inside the ankle, which is formed by the tibia, shown in yellow, the fibula, shown in green, and the talus, shown in red. This is a very complex joint that owes its stability not only to the perfect congruence of the bones, but also to the presence of ligaments located all around the joint. There are also many muscles and tendons around the ankle that allow mobility not only of the foot, but also of the toes. The ankle joint is separated from the muscles and tendons by an anatomical structure called the joint capsule. Think of it as a kind of waterproof bag that surrounds the joint 360 degrees, making it perfectly isolated from everything around it. The inside of the joint capsule is covered with a layer of cells called synovial cells, which produce synovial fluid that nourishes the cartilage and allows the joint to slide. After trauma, even seemingly minor trauma, such as an ankle sprain, but even more frequently after a severe sprain or even a bone fracture, this layer of cells can undergo a significant inflammatory reaction, leading to the formation of tissue that is thicker than normal, which remains inside the joint and can be imagined as cobwebs or scars. These cobweb-like structures form most frequently in the front of the joint, where they can become trapped when the ankle bones move against each other, even when just walking, causing not only pain, but also further inflammation with consequent swelling, and sometimes a feeling of instability in the joint. This is a very common problem that is not always easy to diagnose, because even magnetic resonance imaging, also called MRI, often fails to detect this pathological tissue. The diagnosis begins first and foremost with the clinician's suspicion based on the symptoms reported by the patient. It is not enough to rely solely on the results of an X-ray or MRI, which may actually be perfectly normal. In fact, if the clinical examination and the patient's history raise doubts about this problem, it is always a good idea to perform an infiltration inside the ankle. The injection, called a trial injection, generally consists of a small dose of local anesthetic and a small dose of cortisone. The main purpose of the injection is to see if there is a marked improvement in pain after the injection. The improvement may occur a few days after the injection and will probably last only a few days. However, if the injection does not lead to a lasting disappearance of symptoms, it should not be considered useless. In fact, the injection is not performed with the expectation that the pain will disappear forever, although this sometimes happens, but rather to observe an improvement in pain, even if only for a short period. Only in this case, in fact, can the diagnosis of thickened scar tissue inside the joint be effectively confirmed with reasonable probability. Very often, physical therapy does not lead to improvement, especially considering that the patients I see in my clinic are already people who have undergone many physical therapy sessions after the initial trauma. For patients who have benefited from a cortisone injection, it is perfectly reasonable to suggest minimally invasive arthroscopic surgery. Arthroscopic surgery involves 2 or 3 small incisions in the skin, each about 5 millimeters long, through which we insert a fiber optic camera connected to a screen that allows us to see the problem inside the joint directly. Through the second incision, we insert instruments such as surgical forceps, or instruments that cut and burn scar tissue. The instruments we use through the incisions in the skin are no more than 3 millimeters in diameter. The surgical procedure requires the joint to be continuously irrigated with sterile water, which not only allows the joint capsule to be distended and therefore allows the surgeon to see better, but also allows the continuous removal of small fragments of tissue that are progressively removed. The operation can be performed by pulling the ankle with a traction system such as the one you see here, which increases the space between the tibia and the talus. However, it is still possible to achieve excellent visualization without using this traction system simply by asking the assistant to pull the foot down when necessary. You can now see the presence of abundant scar tissue inside the ankle, while on your right, you can see the ankle of another patient who does not have this problem. It is immediately clear that the ankle on your right is much freer than the one with a pathological condition which you can see on your left. What we need to do now is clean up these cobweb-like structures, mainly using a motorized surgical instrument called a shaver, which you can imagine as a kind of electric razor that cuts and simultaneously aspirates the tissue it comes into contact with. This work is performed in all areas where the tissue appears thickened until the ankle is finally free. While cleaning the tissue, it is possible that some blood vessels may bleed. In this case, it will be necessary to use another surgical instrument to coagulate and then burn the bleeding vessel. This instrument is not strictly speaking a laser, but a radio frequency instrument, which simply transmits a very localized energy that burns the tissue it comes into contact with. Only at this point can the operation be considered complete. We then perform the final washings and close the 2 small cuts in the skin, using a resorbable thread, which does not need to be removed, but will fall out on its own after 2 to 3 weeks. After the surgery, a long boot brace may be fitted, which you will be able to walk in almost immediately. Generally, your surgeon will allow you to put your full weight on the ground. The brace can be temporarily removed, even several times a day, when, for example, you are lying in bed, on the sofa, or even just to move your ankle and, above all, to apply an ice pack to reduce local inflammation. Pain is generally very well managed as long as you do not walk too much and do not strain your ankle, which could otherwise become inflamed and not only swell, but also cause pain. The brace is worn for 1 or 2 weeks, during which time the 2 small wounds must not get wet when showering. It is advisable to use a waterproof bag, which can be found at the pharmacy. The surgery can be performed under general anesthesia or spinal anesthesia, which involves an injection in the back. The operation generally lasts no more than 30 to 40 minutes, and after the surgery, it is generally recommended to have subcutaneous injections of low molecular weight heparin to reduce the risk of deep vein thrombosis, especially if you are a high-risk patient. For example, if you smoke or have a genetic predisposition to developing thrombosis, or if you are taking contraceptives. Your surgeon will tell you if you need to start physical therapy after a week to allow time for the ankle to deflate. As I mentioned, you should apply ice, but for no more than 15 minutes at a time, several times a day, and take the anti-inflammatory medication that will be prescribed to you upon discharge. It is best to be cautious when driving, so it is best to wait at least 2 weeks or until you notice that the ankle has sufficiently deflated and, above all, when you can move it well. Although the surgery is minimally invasive and quick, There are possible complications that you should discuss with your surgeon before undergoing the operation. The risk of infection is extremely low, less than 1%. The risk of deep vein thrombosis, which is a condition when a blood clot forms, especially in the operated leg, is also very low. But to further reduce the risk, it is best to have low molecular weight heparin injections, normally 1 per day for a week. These are small injections and are extremely painless. There is, of course, a risk that the spider veins may reappear, which is why it is important to try to reduce local inflammation immediately with ice and anti-inflammatory drugs prescribed by your surgeon. Physiotherapy can also be extremely useful in reducing the risk of recurrence. In some cases, but no more than 5% of the total, it may be necessary to repeat the cortisone injection if the inflammation of the ankle lasts longer than we normally observe. If the local inflammation lasts longer than expected and your ankle continues to be swollen and painful, thus delaying your functional recovery to return to work or play sports, you will need to continue taking the painkillers that patients normally stop after 5 or 7 days and continue physical therapy for a few more weeks. A rather low risk, but one that is nevertheless described in medical literature, is that of injury to a small nerve that runs along the outside of the ankle, which could cause discomfort such as pain and electric shocks radiating to the outside of the foot. I thank you for your attention, for sharing this video, and for subscribing to this channel.